CTAK, especially for your first cases, should be reserved for patients with typical keratoconus. So we like to look for the standard keratoconic pattern on corneal topography. That is, most of these patients have either central or inferotemporal steepening. We like to have the maximum keratometry and the thinnest pachymetry, that is really the center of the cone for your first case, is inside the 6 millimeter diameter zone. So you can see the top two topographies show typical keratoconic patterns that would be amenable to a good CTAK result. Down below on the left, you see a typical corneal thickness in keratoconus. And again, we're looking at a thin pachymetry, a center of the cone within the 6 millimeter optical zone. We like to use patients who have cones between 50 and 75 diopters for your first case. Of course, there shouldn't be scarring in the visual axis because we're looking for improved visual function and visual acuity afterwards. And in your cases, you should make sure that the area of the femtosecond laser channel that you'll be making is more than 300 microns in thickness. And beware of any scarring that you might have in the femtosecond laser tract because this could interfere with the femtosecond laser itself. And of course, you want to treat patients who need it. So patients who are corrected to 20/20 and doing well shouldn't have the procedure, but it is amenable to patients with a wide degree of incoming keratoconic patterns as well as visual acuities. For your first cases, you do want to avoid patients with a pellucid pattern keratoconus, as you see on the bottom right here, those crab claw appearances where the cone is very peripheral.